Most gynecological procedures are performed with the patient in the supine or lithotomy position. During procedures done on the vulva or done vaginally, the patient will be in the lithotomy position. This positioning puts the surgical technologist in an awkward position, with the back table placed at the foot of the patient, behind the surgeon, or at the side. This requires the surgical technologist to either reach across the front of the surgeon and assistant or pass instruments between them. Neither option is satisfactory, but must be used to preserve aseptic technique. Vulvar surgery is surgery of the external female genitalia. Condyloma is also known as genital warts. They can be removed by laser, bovine, cryotherapy, or excision. No matter what method is used for removal, the smoke evacuator should always be used. If using a laser, then all of the typical laser precautions, such as eye protection and wet towels, should be utilized. Wet towels are used to drape the patient for protection, and no paper products should be used. The wet towels will absorb the laser beam. Acetic acid or vinegar at 3 to 5% concentration can be used on the surgical site. This makes the diseased tissue stand out and give the surgeon better visibility of the lesions. After the surgery, the surgeon will apply Silvadene cream, which is antibacterial. It looks a lot like thick white paste. Surgical excision of the labia, clitoris, inguinal and pelvic lymph nodes is performed to treat cancer of the vulva. A vulvectomy may be performed as a simple or radical procedure. During the simple vulvectomy, only the lesion itself and a small margin surrounding it are removed. The specimen is examined for clear margins, and no further surgery is indicated unless there is extensive involvement. Radical vulvectomy is a complex procedure involving groin exploration, lymph node removal, and wide resection of the lesion and adjacent tissue. Here is an example of stage 4 cancer that has been treated by a radical vulvectomy. Many surgical team members believe that vaginal procedures are contaminated or dirty cases. This leads to poor aseptic technique because the staff members do not feel compelled to exercise care. Any pathogenic bacteria can cause an infection, including bacteria from sources on objects, in the air, and on dust particles. The vestibule, uterus, cervix, and any other perineal structure is not immune to bacterial invasion. Consider a scenario in which an antibiotic-resistant Staphylococcus aureus bacteria, or MRSA, is transferred to the patient's cervix by direct contact with a contaminated glove during surgery. You don't want that to happen to your patient, so always practice your best aseptic technique. Vaginal surgery is surgery on the vagina or surgery on the cervix that is approached through the vagina. Reconstruction of the vaginal walls is called a coporrhaphy. This type of procedure is done to treat a rectocele, a cystocele, and less commonly an enterocele. A cystocele is when the bladder protrudes or herniates into the anterior vaginal wall. A rectocele is when the rectum protrudes into the posterior vaginal wall. And an enterocele is when the bowel, usually the small intestines, herniates into a weakened area between the anterior and posterior vaginal walls. The pelvic floor provides support to the intestines and genitourinary structures, especially during pregnancy when gravity pulls the fetus downward and stretches the ligaments and muscles. As the pelvic floor becomes weakened, the bladder and rectum can bolt into the vaginal canal. Repairing a cystocele is called an anterior repair, and repairing a rectocele is called a posterior repair. These procedures are often done at the same time. This is an anterior and posterior repair or an A&P repair. This procedure is often done at the same time as a vaginal hysterectomy. The surgical technologist will need many Alice clamps available for an A&P repair. A vesico-vaginal fistula is a small tract that connects the bladder to the vagina. A rectovaginal fistula is a tract between the rectum and the vagina. A ureterovaginal fistula is communication between the distal ureter and the vagina. All of these fistulas can be surgically repaired. Retropubic and transobturator suburethral tape has become a common surgical treatment for stress urinary incontinence, which is a leakage of urine when coughing, sneezing, laughing, jumping, walking, sitting, or standing. TVT, or transvaginal taping, is the surgical procedure in which the urinary bladder and urethra are repaired, strengthened, and returned to normal position within the pelvis. The tape is considered an implant and should be touched as little as possible with gloved hands. A D&C is a dilatation and curettage, and a D&E is a dilatation and evacuation. This is also called a D&C with suction. In these procedures, sharp and smooth curettes are used to remove the surface of the endometrium through a transvaginal approach. This procedure is used for diagnostic and therapeutic reasons. A D&C is done to diagnose and treat abnormal uterine bleeding, such as menorrhagia, which is excessive uterine bleeding, and dysmenorrhea, which is painful menstruation, and to remove endometrial polyps. The D&E, or D&C with suction, is used to remove retained placenta and an incomplete or missed abortion. The D&C has a basic setup and order of use. This order is speculum, tenaculum, sound, dilators, cervical curette, uterine curettes, spoon, telfa, sponge stick. Pratt, Hank, or Hagar dilators are used to dilate the cervix, and curettes are used to remove cervical and endometrial tissue. The endometrial tissue is obtained for biopsy, for diagnosis, and or to control uterine bleeding. If a fractional D&C is done, the specimens are endocervical curettings and endometrial curettings. They will be sent on telfa and sent separately. If suction is used, the machine will look similar to this one. The curettes that are used are plastic, and the specimen will be labeled POC, or products of conception.